Hello, I am Maria Serna. I am an anesthetist and I work in a 14-bed critical care unit at Denia Hospital. I am originally from Valencia and I hope you enjoyed your stay with us. And today I'll try to bring you the light on ultrasound and shock. So, the first question that we are going to ask ourselves is, what does a shock look like? Well, a shock patient is usually hypotense, pale, cold, sweaty, and tachycardic. So all the patients on shock look the same. And this is because there's a defect on oxygen delivery, which depends on arterial oxygen content and cardiac output, which also depends on stroke volume and heart rate. So what do we do when we have a patient on shock? Well, the classical assessment is to put him some oxygen, to perform an X-ray, a blood test, and an electrocardiogram. And this is a study of 202 patients admitted to emergency department with non-traumatic hypotension. They were enrolled into two groups. First group received a standard care plus goal-directed ultrasound at time 0. And group 2 received a standard care for 15 minutes and afterwards a goal-directed ultrasound between 15 and 30 minutes after time 0. Physicians indicated the correct diagnosis in 80% of group 1 subjects versus 50% in group 2. After group 2 were crossed over and had received the ultrasound protocol, the correct diagnosis rate increased to 78. So, a goal-directed ultrasound protocol in the evaluation of hypotension results in a more accurate diagnosis. And in 2014, finally, Cecconi published a consensus on circulatory shock and hemodynamic monitoring, telling us that echocardiography allows a rapid characterization of the type of shock and is right now proposed as the first-line evaluation modality. So remember, ultrasound goes first. And there are several reasons why to perform an ultrasound. But these are my best 10 reasons. It's portable anywhere. They're smaller and portable. We can go to the operating room, to the emergency room, and critical care unit. It's dynamic in time. It's non-invasive. It's use. It's fast, cost-effective, it's low cost. It provides accurate measurements and it offers diagnosis not only of the cause of shock, but also dyspnea and bleeding, and the guidance for procedures and also for therapies. And I have been in a battle session about the ideal team leader. Most of the speakers talked about using ultrasound on trauma patients. So I have to think about it, and because this can be you on board in front of a patient on shock who's been recently operated. And how are we going to perform it? Well, with a point of care ultrasound. In the last years, several protocols have been published. The AIMS protocol, the FATE protocol, the ACEs, the Rush examen, the FALS protocol, but they all have the same goal, and that's a tailored ultrasound. If we imagine the cardiovascular system as an engine with its pipes, which has the mission to transport the oxygens to the cell, depending on where the defect is, we'll have a different origin of shock. If the pump failures, what we're going to have is a cardiogenic shock. If we have a plug effect like a cardiac tamponade, like a pneumothorax or a pleural effusion or a thromboembolism on the pipes, what we're going to have is an obstructive shock. If the system is empty because of dehydration or bleeding, what we're going to have is an hypovolemic shock. And when the defect is on the pipes because they're excessively vasodilated, what we're going to have is a distributive shock. So to determine the cause of shock, we're going to look for the pieces to make our puzzle and try to give them sense. We're going to start with the heart, the pump. First of all, looking at the pericardial sac. We have the objective to determine a pericardial effusion that may be compressing the heart, that we're going to see like a hypoechogenic area around the heart. And in my opinion, seeing one, seeing all, it is very easy to see. Then we're going to look at the left ventricular function, which classically the cardiologists use the ejection fraction. That it's the difference between the diastole and the systole. But don't get panicked because this is easier and we can make an eyeball assessment. And the first video, what we have is a normal ejection fraction, but you can see the difference between this video and the video on the bottom of the slide, where there's not many difference between the diastole and the systole. And this is a video of a cardiac failure with a low ejection fraction. And at the top right, what we have is a septic shock with an hyperdynamic and high ejection fraction. And now we're going to take a look at the size of the chambers, because the right ventricle, it's like a balloon and is very sensitive to changes in pressure and volume. So its normal size, it's the 60% of the left ventricle, and it usually dilated when there's a thromboembolism. It's bigger than the left side. We have the opposite effect when we have an hypovolemia with a hyperdynamic ventricle function, and it's collapsed. Now let's take a look at the inferior vena cava, where we can determine its size and collapsibility with ultrasound. It gives us information about the right atrial pressure and the central venous pressure, and its respiratory dynamics provides an assessment of the patient's volume status. Next step is take a look at the lungs. We're going to study the blue points with the objective to rule out a pneumothorax, a pleural effusion, or a pulmonary congestion responsible or involved in a shock patient. So its normal anatomy consists in the soft tissue. Then we see a white line, which represents the pleural line. And then what we have is the lung. And if we put the M mode, what we're going to see is a seashore sign. And on the top, the water is going to be the thoracic wall. And at the bottom, what we are going to see is the sand, which corresponds to pulmonary parenchyma. When the seashore sign disappears and we have a cold bar sign, what we have is a pneumothorax. Sometimes what we have are white lines which depart from the pleural line, which are called B-line artifacts or comet tails, which correspond to pulmonary edema. In this case, for example, secondary to cardiogenic shock. Then we're going to look at the Plep's point, and we're going to search for a pleural effusion, a pulmonary contusion in a polytraumatic patient, or an hemothorax with a tissue-like sign. Then we're going to go to the abdomen to identify free liquid responsible of an hemoperitoneum. These are our views, and the subxiphoid view, we're already seen it before. So we're going to see the liquid as a hypoechogenic area. In the first case, in the hepatorenal recess or Morrison pouch. Here we see an hypoechogenic area, subphrenic, above the spleen. And here what we have is blood in a pelvic window, where we see the bowels swimming and a black space. And finally, we're going to assess the pipes to see if there's any rupture or obstruction. Here we have an aneurysm, an abdominal aneurysm, which is broken. We see again an hypoechogenic area around the aneurysm. And here we have a plug effect. We have to identify a lack of full venous compression to diagnose a deep venous thrombosis. In this case is the jugular vein, which is thrombosed in a patient with a pulmonary embolism. So once we have all the pieces, what we do is to put them together to build our puzzle and rule out the shock that our patient has to give them a treatment. And how are we going to learn this? Well, there are different programs. There's a music program with a theoretical training, 10 hours program involving a pre-reading, didactic teaching, and interactive cases, which can perfectly be done online, but this has to be completed with a hands-on training. Usually general ultrasound are recommended at least 10 ultrasound explorations, and echocardiography is a little bit more complex, and the basic skills we acquire with 30 explorations, and advanced would be much more. Always to establish diagnosis and procedures guide. So take home that ultrasound is a safe, rapid, and useful technique in unstable patients. A goal-directed ultrasound protocol into the routine evaluation of patients with shock leads to a more timely and more accurate diagnosis of these critical ill patients. An acquired competence takes only a 10-hour course and 10 explorations for general ultrasound and 30 for basic echocardiography. So take home and think about it, because fear of a diagnostic error raises concerns. But when the considerable benefits it confers to patients are well known, non-utilizing ultrasound could be inexcusable. So thank you very much for your attention.